So we're going to be talking about central scotoma. Scotoma is obviously a visual field defect, and in this case, it's in the center of our vision. So the first thing we need to know is it unilateral or is it bilateral? When it's bilateral central scotoma, we need to make sure it's not the macula or the papillomacular bundle. If it's the macula, that's retina. And normally OCT can answer the question of macular disorders producing a unilateral or a bilateral central scotoma. A macular hole, epiretinal membrane, anything that's in that macula will normally be able to see if it's producing a central scotoma on macular OCT. If it's not the macula and it's optic nerve, the differential diagnosis for a central scotoma that's bilateral is quite limited. And what it looks like on visual field is it's literally a central scotoma, a black spot right in the center of your vision. Now sometimes the black spot extends to and involves the blind spot, and that we call a central scotoma. But a central scotoma and a central scotoma have the same localizing significance. It's either macula or it's papillomacular bundle if it's an optic neuropathy. And so even though the chance of this being a compressive lesion is low, I usually recommend that we do an MRI of the head and orbit with gadolinium on every patient who has a central scotoma, regardless of whether it's unilateral or bilateral, assuming the OCT doesn't show its macula. If it's bilateral, then we're thinking about systemic things. Toxic and nutritional are the most common, and the most common toxin that we see is alcohol. So we can have toxic nutritional amblyopia, a toxic nutritional optic neuropathy from alcohol consumption, and that usually leads to B12 and folate deficiency. So toxic and nutritional tend to run together in terms of ethanol because it is B12 and folate are the vitamins that the papillomacular bundle needs the most to maintain its metabolic activity. So when we have a central or central scotoma, it's the highly active papillomacular bundle that feels the metabolic derangement first. And so when we do B12 and folate, we also have to consider the addition of long-term tests for B12, which is methylmalonic acid and plasma homocysteine. So in methylmalonic acid, that is involved in the conversion of the methylmalonic acid to succinyl-CoA, the entry molecule into the Krebs cycle. And so this is like a hemoglobin A1C of our B12 level. You cannot rely on the spot B12, or if the B12 level is borderline, like 200 or 300 or 400, we will still do MMA and homocysteine. If the homocysteine is elevated but the MMA is normal, that usually suggests it is folate and not B12 deficiency. Homocysteine is converted to methionine, and that is a folate and B12 dependent pathway. The conversion requires methylene tetrahydrofolate reductase, the enzyme that assists in that conversion of dihydrofolate to tetrahydrofolate is a folate dependent pathway. And so if we have elevations of both, we're really thinking about B12. If we just have homocysteine, folate. You need these to differentiate these because treatment of either condition with the other will mask the hematologic abnormality without improving the neurologic abnormality. So we really need to know, is it B12, folate, either, neither, or both. The hereditary thing that we're worried about with the central scotoma is labor hereditary optic neuropathy. And that's usually in a young male. That's a mitochondrial disorder. You can check out the YouTube on the labor, which is separate, and in the autosomal dominant form, which is also mitochondrial, even though it's inherited in autosomal dominant fashion, optic atrophy genes, including the OPA1 series. And the toxins in the acute setting are methanol, so that's alcohol, it's mixed with wood alcohol, methanol, that's moonshining, or your drink has been poisoned for some reason, or you're trying to kill yourself, or someone's trying to kill you. And the other toxin that we worried about are the medications that we are giving patients. So normally the prototype is ethambutol, which is used for mycobacterium, including tuberculosis and non-tuberculous mycobacterium family. So ethambutol is the central scotoma prototype for toxic optic neuropathy. If it's a unilateral central scotoma, that can be any optic neuropathy. And so we still need to do the MRI scan on that person, and we're going to be doing the usual suspects. You can check out on the other video about optic atrophy what tests we would do, syphilis serologies, NMO, MOG, the other tests for an optic neuropathy that is unilateral or bilateral, which we call the usual suspects. So when you're dealing with a central scotoma, you'd like to know if it's unilateral or bilateral. If it's bilateral, the hereditary conditions, labors, OPA1, and toxic nutritional, in the acute setting, methanol, in the chronic setting, alcohol. B12, folate, MMA, and homocysteine, the hemoglobin A1C of B12. Do an MRI scan, and I usually treat the patients empirically with B12 and folate while I'm waiting for the test if there's any suspicion that they have a nutritional deficiency.